गुड इवनिंग सर। सुधीर सर, गुड इवनिंग।
गुड इवनिंग सर।
हाँ, गुड इवनिंग प्रमोद।
गुड इवनिंग
प्रणाम सर,
तिवारी
कमलेश
सर।
तिवारी सर, प्रणाम।
प्रणाम 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 प्रणाम। तो ट्रांसफर कर दूंगा नीचे से।
ज्वाइन कीजिए,
क्या लाइट
ज्वाइन कीजिए।
को पूछा।
तिवारी सर, आप बहुत पंक्चुअल हैं। इतना बिजी शेड्यूल में भी एकदम पहले ज्वाइन किए हुए।
आदत से भैया ना।
जी सर, जी सर, ये आपसे सीखने की चीज है सर।
वो भी बहुत कुछ छूट जाता है।
नहीं सर, बाप रे बाप, आप बहुत अच्छा खासा टाइम देते हैं यार।
अभी दो काम लेके एक साथ चल रहे हैं, ये ज्यादा
जी सर।
मुश्किल है, हैं?
जी 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 जी।
एक तरफ कॉन्फ्रेंस, एक तरफ आईसीपी,
दोनों ही इम्पोर्टेंट है।
दोनों ही इम्पोर्टेंट।
सर सर गुड इवनिंग सर।
गुड इवनिंग, गुड इवनिंग।
प्रणाम सर।
गुड इवनिंग।
सर पाल सर ज्वाइन करेंगे क्या?
हैं?
हाँ
ज्योतिर्मय पाल सर ज्वाइन करेंगे क्या?
हाँ, मोस्ट प्रोबेबली बोले थे कि हम ज्वाइन करेंगे।
ठीक है सर।
रिमाइंडर हम दे दिए हैं।
जी
और
सर।
ज्यादा उम्मीद है।
आज मुझे लगा कि सारे, हाँ, बहुत सारे जगह एक्टिविटीज हो रही हैं।
हाँ 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 हाँ, बेशक। वो तो असल में अब नेशनल लेवल का आदमी को तो 25
हाँ
जगह
सर।
जाना है। ये तो, और अपने स्टेट का तो करना ही है सब।
जी सर। नहीं, आपका भी अच्छा था सर। हमने आपका पूरा वो वीडियो देखा, वो बहुत अच्छा अच्छा था।
बहुत
बिहार में भी
सक्सेसफुल।
मतलब 5-6 सर, मैं तो एक्चुअली 2 दिन से हमारे यहाँ एक्चुअली इमरजेंसी मेडिसिन का एक कुछ प्रोग्राम चल रहा था, तो मैं आज के दिन का कोई प्रोग्राम अटेंड वो करा नहीं पाया। नहीं तो, लेकिन अब बहुत लोगों ने बहुत कुछ किया, अच्छा किया। मुजफ्फरपुर से अमित सर का भी बड़ा अच्छा था, जो उन्होंने वीडियो पोस्ट किया।
बहुत अच्छा था, बहुत अच्छा।
हाँ। थोड़ा
हम
सा
लोग तो
वाइब।
लगभग लगभग 200 पेशेंट था।
जी जी
सारे
सर।
स्टूडेंट थे।
हम्म।
और अच्छा इंटरेक्टिव हुआ।
हाँ।
पेशेंट लोग भी खूब क्वेश्चन वगैरह पूछा, हम लोग भी अपना उस लोगों का सॉल्व किए जो हो सकता था।
नहीं, हम आवाज गड़बड़ा रहे सिलेंडर।
सर आपके, हाँ सर की
और
आवाज नहीं आ रही।
उतना बड़ा नहीं जितना बड़ा कटिहार में आप किए हैं, लेकिन मेरे यहाँ। प्रणाम सर, प्रणाम। अच्छा, नहीं किया हुआ है, नेटवर्क का प्रॉब्लम हो सकता है कुछ।
जी सर। जी सर।
शैलेंद्र सर, आप लोग का वो वीडियो बहुत बेजोर था।
कौन? हाँ, वीडियो तो मैंने अमित का आइडिया था।
हाँ, आइडिया तो आप सभी सभी ने, मैंने अमित तो किया ही
आइडिया
किया,
था।
लेकिन काफी अच्छा था।
अच्छे परफॉर्मेंस भी अच्छे थे एक्चुअली।
सर को प्रणाम, कमलेश तिवारी सर को प्रणाम।
प्रणाम
आवाज आ
प्रणाम।
रही है?
आवाज आ रही है, आ रही है, अब ठीक आ रही है।
हाँ सर,
आज
अब
मेरा
तो थोड़ा सा
वाईफाई भी
वाइब्रेंसी
चल रहा
लग रही होगी
सर।
सर।
हैं?
सर कुछ वाइब्रेंसी लग रही होगी सर, एपीआई बिहार के में। सर कह रहे थे कुछ काम नहीं हो रहा है, कुछ काम नहीं हो रहा है।
तीन
सर
महीने के बाद, 3 महीने के बाद ये पहला दिन हम देख रहे हैं।
सर
तिवारी
सर
तिवारी
पहला
सर,
महीना तो एपीआई में निकल गया, एपीकॉन में हम
नहीं
क्या
नहीं,
करें।
एपीआई क्या, वो आईसीपी एपीआई सर का इतना क्लासेस पर रोज रोज क्लास, तो लगता था कि क्या एक्स्ट्रा एक्टिविटी करवाएं।
सीरियसली।
लेकिन सर आप परेशान हो जाइएगा।
अब हम कुछ नहीं करते हैं, अब हम कुछ नहीं करते हैं, खाली रूटीन चेकअप करते रहते हैं,
आप
ज्यादा
आप
कोई अटेंड नहीं करते हैं।
अगले 2 महीने का सर फाइनल हो गया है। अगले महीने हम लोग मुंगेर जा रहे हैं, उसके अगले महीने बेतिया जा रहे हैं, और ये कंटिन्यूटी मेंटेन रहेगी सर
ठीक ठीक
हर
ठीक
महीने की।
ठीक।
कोशिश कर रहे हैं कि फर्स्ट वीक ऑफ जून में कटिहार आप लोग को बुलाएं, और उसके लिए कुछ मीटिंग्स है वो कर लेते हैं हम लोग। अगर फाइनल हो जाता है तो सर आप लोग हम लोग को प्लेस करने के लिए जरूर आइए।
बिल्कुल बिल्कुल।
सर हम लोग 8 o'clock पे शुरू कर देंगे ना?
हाँ हाँ हाँ।
हाँ कर देंगे।
हम जरा पाल सर को बात करते हैं।
देव कुमार, तुम्हारे चेहरा पर दूध चेहरा आ रहा है क्यों?
ज्वाइन कीजिए सर।
देव कुमार वीडियो ऑन करो।
बहुत दिन के
अब
बाद देव कुमार बॉस को बहुत दिन बाद देख रहे हैं।
अब देव कुमार का ओरिजिनल लगता है आया, कहाँ गया?
गुड इवनिंग लक्ष्मी मैम।
अभी भी दो है। ज्योतिमय ज्वाइन कर लिया, बुलाइए बुलाइए।
अभी सर किसको नहीं है।
ज्योतिमय चेहरा दिखाइए।
हाँ, चेहरा बिना देखे सर सब बेकरार है।
तब ना शुरू करेंगे।
Good evening all. Today is 24th of March 2025, and we are celebrating World Tuberculosis Day. It is the day when Dr. Robert Koch discovered the bacteria, Mycobacterium tuberculosis, and for this we celebrate this day since 1983. So today we have gathered to discuss about what the current situation of tuberculosis in India and worldwide. So I hand over my mic to our API Bihar chairman, Dr. P.K. Agrawal sir, to start the proceedings. Sir.
Thank you, Dr. Divendu. Good evening, all. It is my great honor and privilege to welcome you all to this continuing medical education session on tuberculosis, organized in observance of World Tuberculosis Day. First of all, I welcome our President, Dr. Jyotirmay Pal sir, Dr. B.B. Thakur sir, past President API and past Dean API, Dr. Kamlesh Tiwari sir, past President API and presently Dean ICP, and Dr. Governing Body Member, Dr. DP Singh sir, yet to join Dr. Hemsankar sir, Dr. PK Sinha sir, Dr. Devi Nam sir, Dr. AK Das. As we gather here today, we are reminded of the ongoing battle against one of the world's deadliest infectious diseases, a battle that requires persistent efforts in prevention, diagnosis, and treatment. World Tuberculosis Day is observed annually on March 24th to observe the discovery of Mycobacterium tuberculosis by Robert Koch in 1882, as said by Dr. Devenu. Despite the progress made over the decades, tuberculosis remains a major global health challenge affecting millions of lives, especially in high-burden countries like ours. The emergence of drug-resistant tuberculosis and the need for more effective strategy to eliminate the disease make it imperative for us as healthcare professionals to stay updated with the latest advancements and the best practices. But our government made a great effort, and you will be happy to know the incidence rate decreased by 17% and death rate decreased by 20% in comparison to 2023. This CME session aims to provide a comprehensive update on TB, covering crucial aspects such as recent updates of drugs-resistant tuberculosis and recent diagnostic method for tuberculosis. I extend my sincere gratitude to all the distinguished speakers, today's speakers, Dr. Pallavi Gopichand and Dr. Manish Shankar. The chairperson will introduce them who have joined us today. Your dedication to the cause of TB elimination is truly commendable. Let us use this opportunity to learn, collaborate, and reaffirm our commitment to ending TB once and for all. With that, I officially inaugurate this CME on tuberculosis. First of all, I welcome and want Dr. Jayapal to bless this occasion with few words. Dr. Pal, sir.
Good evening, Dr. B.V. Thakur, our mentor, past president API, past dean ICP, Dr. Kamlesh Dehari, dean Indian College of Physicians and also past president, Dr. P.K. Agarwal, chairman API Bihar chapter, Dr. D.P. Singh, Dr. Hem Shankar, Dr. Dibyendu Bhushan, secretary API, and all my colleagues, students. This is my pleasure that entire country, our all state branches and city branches are observing World Tuberculosis Day. Today is the discovery day of tuberculosis by Robert Koch in 1882. And every year we observe this day worldwide. Why? Because this disease is present for 4,000 years. There is even in Egyptian, and there are many great societies either suffered or died from the tuberculosis. Still, in spite of diagnostic avenues and also management, treatment, medicines, and widespread availability of medicines by the different government, WHO, but still we fail to cure this disease. We have a goal set up by the WHO by TB-free world by 2030, and our government India has set up 2025. But in spite the incidence of tuberculosis decrease, but we are far from achieving this goal. This day is important because this gives a reminder to the physicians that apart from treatment of this disease, we should involve ourselves in the public awareness program, in the prevention of the disease. Because prevention is always better than the cure. So not this day. Our physicians, our practitioners, whether you are physician, gynecologist, cardiologist, nephrologist, we all should propagate the knowledge of prevention of tuberculosis among the entire 140 crore population of India. And this is the way, if we are active 365 days, only we can prevent this disease and we can achieve the goal. I think today's seminar will remove many misconceptions that is prevailing within the physicians and practitioners. And I congratulate the initiative taken by Bihar API chapter to educate, to update the members regarding the TB management. Thank you. Over to Dr. P.K. Agarwal. Thank you.
Hello. Hello.
Yes, sir, you are audible, sir.
Now, I request Dr. Kamlesh Tiwari, sir, present Dean ICP to bless the occasion.
Thank you, Dr. Agarwal. You have already mentioned that tuberculosis is very important for us because we have seen tuberculosis from very beginning of our childhood, and still we are treating the tuberculosis. And I don't think there is much change from those days to this day. Yes, diagnostic facilities and treatment has extended. We are dealing more with resistant tuberculosis. So today, Dr. Manish is going to give us a current update in management of resistant tuberculosis. Thank you all, and I hope things will go all right. Dr. Manish, please.
थैंक यू सर. सभी गुरुजनों को मेरा प्रणाम. Am I audible, sir?
Yes, yes.
Audible.
Is my slides visible?
Yes, sir.
Okay, sir. Thank you. सभी गुरुजनों को मेरा प्रणाम और उनके आशीर्वाद के साथ ही मैं ये अपना टॉक शुरू करूंगा. तो regarding tuberculosis is really a menace, and in spite of government program running all over India, the incidence and prevalence of TB along with drug-resistant TB is increasing day by day. There are still paucity of newer drugs available in our program. There are several drugs right now. Within 3 or 4 years, we have bedaquiline, we have delamanid, we have linezolid in the armamentarium of treatment of drug-resistant TB. Despite that, the prevalence of drug-resistant TB is increasing. Although these regimens, these drugs are very effective in managing TB. And with the arrival of newer drugs like pretomanid, the WHO has updated the management of drug-resistant TB guidelines. And before, we were treating drug-resistant TB with 18 to 20 months of drugs, the treatment. Now, treatment has really shortened down to 6 to 9 months. And this has been found to be very effective in number of trials, in a robust trial, RCTs, that these regimens are very effective. So my focus will be on what are the current updates in the management of drug-resistant TB. So you all know that India has almost 27% of drug-resistant TB in the entire world, as per the Global Tuberculosis Report 2024. Among MDR TB, around 3% MDR TB is found in new TB cases and 13% in previously TB cases. And with the arrival of with the inclusion of newer regimen, the treatment success rate has improved almost up to 74%. And of pre-XDR TB, it has improved up to 68%. And treatment success rate has been reported in MDR TB by all oral longer regimen up to 73% in 2021. So what are the current updates? It has been recently included in the November 2024, and WHO has recommended that all patients of drug-resistant TB, including that who are resistant to fluoroquinolones, that is called pre-XDR TB, can be effectively managed with all oral treatment regimen. Before 3 or 4 years back, before we were using injectables in the drug-resistant TB treatment, and it was very cumbersome. Many of the patients were defaulters due to injections-related complications. Then WHO included all oral regimens in the treatment of multi-drug resistant TB. And these all oral regimens can be shorter, that is of 9 to 11 months, or longer, 18 to 20 months. And it was implemented under programmatic conditions. it was not over-the-counter medications that were available. Now in November 2024, our program has included 6 months of BPAL-M regimen. B stands for bedaquiline, P stands for pitomonid, L stands for linezolid, and M stands for moxifloxacin. And this has really reduced the regimen duration almost from 18 to 20 months to 6 to 9 months. And it has to be used programmatically. So now the treatment regimen have 4 options. First and foremost is BPAL-M, that is shorter oral regimen of 6 to 9 months. If a patient is not eligible for BPAL-M, then we will use 9 to 11 months of shorter oral MDR-TB regimen. If patient shows additional resistance or not effectively managed with these 2 regimens, then we will use 18 to 20 months of longer oral MDR regimen. And for H monoresistant, that is isoniazide monoresistant TB, we will use 6 to 9 months of levofloxacin REZ regimen. So these are the preferential orders 1, 2, and 3, as I have already discussed. So current update is where BPAL-M cannot be used. Suppose first and foremost is BPAL-M, but if BPAL-M cannot be used, then we will use shorter oral bedaquiline based regimen instead of longer oral bedaquiline based regimen, that is of more than 18 months, provided that the tuberculous bacilli is showing no resistance. It means sensitive to fluoroquinolones. That is not pre-XDR, only MDR, and patient is having no extensive pulmonary TB disease or extrapulmonary, suppose tuberculous meningitis or severe pericarditis or ocular tuberculosis. And one more thing has been added in shorter oral bedaquiline based regimen. We were using ethionamide, but ethionamide is very unpalatable. One have used ethionamide, they can say that it is so much impalatable, not palatable, that patient almost having retching and vomiting tendency. So now linezolid of 2 months is being used in the regimen as an alternative to 4 months of ethionamide, and it has been found to be very effective. And only patients with XDR TB who have been failed shorter regimen or are showing resistance to shorter regimen will be provided longer oral regimen of more than 18 months. One more thing has been added in the diagnostic part, that CBNAT we are using is showing resistance to rifampicin only. But now it has been added that CBNAT is not only showing resistance to R, but second generation CBNAT is also showing resistance to H, fluoroquinolone, SLID, and ethionamide at the laboratories equipped with the technologies. So CBNAT is now more effective so that we can upfront diagnose not only rifampicin resistance, but also second line drugs also, such as fluoroquinolones, such as SLID and ethionamide also. That is major advantage. So this is the treatment algorithm for drug susceptible and drug resistant tuberculosis we have right now. First and foremost, any patients who are suspected to be having tuberculosis should be subjected for upfront sputum examination by CBNAT and at least 2 specimens should be collected and test for resistance to either rifampicin, isoniazide, fluoroquinolones, or other drugs as needed. Then we have 2 scenarios. Either we have MTB detected and rifampicin resistance detected, or we have MTB detected but rifampicin resistance not detected. Then we will see the age of the patient. If age is more than 14 years, then these patients are eligible for BPAL-M regimen. And if age is less than 14 years, then these patients are eligible for shorter or oral longer regimen. Second scenario is MTB positive, but rifampicin resistance is not detected. Then these patients are considered to be drug sensitive TB. And we will start 6 months of treatment with 2 months of HRJD with 4 months of HRE. But before starting or once we have started these treatment, second sputum sample should be sent for H resistance or LPA examination to detect whether these patients are having isoniazide monoresistance or not. If patient is having isoniazide monoresistance, then these drug sensitive TB treatment is not going to work. So if H resistance is not detected, then we will continue with this treatment. But if H resistance is detected, then we will treat these patients with levofloxacin in place of isoniazide, along with rifampicin, ethambutol, and pyrazinamide from with the treatment duration of 6 or 9 months. So what are the evidences we have for the newer drug-resistant TB oral drugs and the regimen? When next TB trial came in 2020, it caused a ripple effect. It got betacholine, pritomonid, and linezolid, and it was found to be very effective, almost 90% treatment success rate, especially in pre-XDR TB patients. So program allowed in PMDT program allowed to implement this in India under Operation Research condition. Then came the TB practical trial, which was published in New England Journal of Medicine in 2022. It recommended BPAL-M regimen, and it showed favorable efficacy, almost treatment success rate of 89%, and of considerable safety when compared with the control arm of the TB practical trial. So based on these trials, program implemented BPAL-M regimen. So once we start BPAL-M regimen, we have to consider for the age. If age is more than 14 years, then eligibility has to be assessed and inclusion-exclusion criteria should be seen. And then we do the pre-treatment evaluation. We see the relative contraindications and we start BPAL-M regimen. So what does BPAL-M regimen has? BPAL-M has bedaquiline, which inhibits mycobacterial ATP synthase. Pritomonid, it blocks cell wall production. It causes nitric oxide release, and it has been approved to use only with BPAL or BPAL-M. Linezolid disrupts protein synthesis, and moxifloxacin, we all know, inhibits DNA synthesis. So ICMR also conducted health technology assessment and the cost effectiveness of BPAL-M, and it found it to be really cost effective in comparison to all oral longer regimen. And emerging global evidence also suggests that 6 months of BPAL-M regimen are cost effective and of improved compliance. Then came the MBPAL, that's a modified BPAL trial. What happens in next TB trial? They were using 1200 milligram of linezolid. That was really toxic to the patient because several of the patients developed severe neuropathy and ocular toxicity. Then BPAL-M regimen came with 600 milligram of linezolid. And we have the experience of treating MDR TB, and we have seen that linezolid, even of 600 milligram, if used for long duration, can cause severe neuropathy, and many of the patients have to be stopped of linezolid because of ocular toxicity and severe peripheral limb burning sensation. So modified BPAL trial came with the idea of whether we can decrease the dose of linezolid further. So they have 3 arms. One arm which use 600 milligram of linezolid for 26 weeks. Second arm use 600 milligram of linezolid for 9 weeks, then 300 milligram for 17 weeks. And third arm, they use 600 milligram for 13 weeks and 300 milligram for 13 weeks. And it was found out that linezolid-related toxicity could be effectively reduced with the dose reduction of linezolid from 600 to 300 milligram, but only after 9 to 13 weeks. Before that, if the patient develops toxicity to linezolid, then we have to stop the regimen, consider it to be failure, and treat the alternative regimen. So, linezolid dose can be reduced only after 9 weeks. So, regarding inclusion criteria of BPAL-M regimen, age should be more than 14 years, and patients should show sensitivity to the drugs used in BPAL-M regimen, or if we do not have any sensitivity report available, then there should be history of intake should be less than 1 month. QTCF should be less than 450 millisecond in males and 460 milliseconds in females. Excuse me. Females should be non-pregnant or non-lactating, and patients should have no liver function derangements or serum creatinine should not be high. If there is severe extrapulmonary tuberculosis, then BPAL-M regimen cannot be used. If there is severe cardiac conduction abnormality, anemia, if hemoglobin levels less than 8 gram percent, or platelet count less than 1 lakh, or leukopenia severe, or neuropathy severe, then we cannot use BPAL-M regimen. And BPAL-M regimen has bedaquiline 400 milligram is used 2 weeks 400 milligram, then from 3 to either 26 weeks or 39 weeks 200 milligram thrice a week. Pretomonic 200 milligram daily, linezolid 600 milligram for 26 weeks. But if we have to reduce the dose of the linezolid from 600 to 300 milligram, then we have to extend the treatment up to 39 weeks, and moxifloxacin for 400 milligram is used. And all patients should be above 14 years of age, and there is no weight bands. We all know that tuberculosis therapy is dose is given as per weight bands, but for BPAL-M there is no weight bands. And all the patients should be provided with pyridoxine. It has got added protection against neuropathy. So one thing is, when we are using BPAL-M, it contains moxifloxacin. And many of the patients of pre-XDR TB are almost resistant to fluoroquinolones. Then how we can give moxifloxacin in a patient who is already resistant to fluoroquinolones in BPAL-M regimen? Then there are several studies who are advocating moxifloxacin in spite of tuberculous bacilli showing resistant to fluoroquinolones. And one is TB practical trial. It has got 3 arms. One is BPAL-M, another is BPAL-C, that is clofazimine, and third is BPAL. And in these 3 arms, almost 23% of patients were FQ resistant. And it has shown that 77% of the patients in BPAL-M regimen showed culture conversion to negative in comparison to BPAL-C and BPAL group, in spite of bacilli is resistant to fluoroquinolones. In BPAL-M regimen, it showed low recurrence and probable protection against amplification of bedaquiline resistance. You can see that bedaquiline disease recurrence was only 1% in BPAL-M group as compared to 4% in BPAL-C group. Treatment outcome was also better in BPAL-M group, that is 77%, as compared to other groups. Culture conversion time was also comparable to other arms. Safety outcomes were also favoring BPAL-M group, and QTC prolongation was lower in the BPAL-M group as compared to BPAL-C and BPAL group. US programmatic data also used Bipal-M in comparison to Bipal, and they show that 81% of the Bipal-M regimen completed treatment in comparison to 72% of the Bipal group. TB relapse was only almost 0% in Bipal-M group as compared to 3% in Bipal regimen. So, this is all for Bipal-M. Bipal-M is showing very efficacious result, and program has now implemented Bipal-M group in the treatment of drug-resistant tuberculosis. But if patient is not fit for Bipal-M or not eligible, then we will, those patients are eligible for shorter oral regimen, that is 9 to 11 months of shorter bedaquiline based regimen. So shorter oral bedaquiline based regimen is given for 9 to 11 months, and it is preferred over longer 18 to 20 months of longer regimen, provided that the bacilli is not resistant to fluoroquinolones and there is no extensive pulmonary TB disease or severe extrapulmonary TB disease. And if bacilli is resistant to isoniazide, then it should be either resistant to INHA or showing mutation to CAT gene, not both. There should not be any fluoroquinolone resistance, and there should not be any history of exposure of more than 1 month of the drugs being used in shorter or bedaquiline based regimen. There should not be any extensive TB disease, and there should not be any severe form of EPTB disease or disseminated TB disease. Pregnant female were not given shorter oral regimen if pregnancy of below 32 weeks when we were using ethionamide, but now linazolid has replaced ethionamide. So pregnant female can be given shorter oral regimen containing linazolid. So this has been explained. So shorter oral bedaquiline based regimen is 6 months of bedaquiline along with 4 to 6 months of linazolid, clofazimine, pyrazinamide, ethionamide, and isoniazide high dose, along with linazolid of 2 months, followed by 5 months of levofloxacin, clofazimine, pyrazinamide, and ethambutol. So, ethionamide has been replaced by linazolid in the regimen, so it can be given to pregnant female. But suppose if bacilli is resistant to linazolid, then we can use ethionamide for 4 months. But if any other drug is showing resistance, suppose pyrazinamide is showing resistance, then we have to terminate the shorter oral regimen and we have to start all oral longer regimen. So if any other drug is to be replaced or has to be stopped due to any reason, either unavailability or due to showing resistance or toxicity, then we have to terminate the regimen and we have to start all oral regimen. So regimen I have already discussed. So how to extend the intensive phase? Intensive phase is 4 to 6 months. So for initial 2 months, we will give linazolid. Then we will give remaining 5 drugs, levofloxacin, clofazimine, pyrazinamide, ethambutol, isoniazide high, and bedaquiline for 2 months. So total 4 months and bedaquiline up to 6 months. Then if 4th month sputum is either smear positive or culture positive, then we will extend the treatment up to 6 months and bedaquiline up to 9 months, followed by extension phase. Isoniazide high will be dropped after 6 months. So after shorter regimen, if shorter regimen is showing additional resistance and we have to drop the regimen, or patient is showing resistance or the non-availability of any drug, then we will straight away start all oral regimen, provided the patient is not eligible for shorter oral regimen, or provided the patient is also not eligible for BPAL-M regimen. So this is the longer oral MDR regimen, 18 to 20 months of levofloxacin, bedaquiline, linezolid, clofazimine, and cycloserine, where bedaquiline is given for 6 months, can be extended depending upon the conditions. In this regimen, there is no separate intensive phase and continuation phase. Pyridoxine has to be given to all patients, and for XDR-TB, regimen will be for 20 months. So this is what for longer oral regimen. Now coming on to the isoniazid resistance cases. I have already mentioned that any patient of drug-sensitive TB should be subjected for first and second line LPA. And if LPA is showing resistant to isoniazid, then we should not give drug-sensitive TB regimen, and we should start levofloxacin REZ in place of isoniazid. And we should, this regimen is given for 6 months, and if smear is positive, 4th or 5th month smear is positive, then we will give total duration for 9 months. This is for 6 or 9 months, not 6 to 9 months. There is no separate IP or CP, and we should reflex test for second line LPA also, because some patient may be resistant to fluoroquinolones. Then we will try alternate regimen. In place of levofloxacin, we can use linezolid. If the patient is also showing resistance to linezolid, then we can use cycloserine and clofazimine. So joining all parts together, first and foremost, upfront sputum examination, upfront CBNAT, upfront FLLPA, SLLPA. If more than 14 years, then BPAL-M. If less than 14 years and not eligible for BPAL-M, then shorter oral regimen. If patient is not eligible for shorter oral regimen, then we will start longer oral regimen. For isoniazid resistance, if rifampicin sensitive and isoniazid sensitive, then 2 months HRJD followed by 4 months of HRE. If H resistance, then 6 or 9 months of levofloxacin REZ. That is all from my side. If any question is there, then I will be happy to answer. Thank you.
Thank you, Dr. Manish. Before moving forward, I first want to introduce the great chairperson, the learned chairperson, who of course need not need any introduction. The first one is Dr. Ajay Kumar Sinha sir, HOD, NMCH, and Dr. Abhilesh Kumar, Professor and Head, Jawaharlal Nehru Medical College, Bhagalpur. Sir, Dr. Ajay sir and Dr. Abhilesh sir, you please carry the scientific session further on. And I request all the governing body members and all the seniors, please stay with us, and we need their blessings at the end of this scientific session. Thank you. Dr. Ajay sir and Dr. Abhilesh sir, you please carry forward the rest scientific session.
Thank you, Dr. P.K. Agarwal. Thank you for inviting. And good evening, everybody. My regards to seniors. Thank you, Dr. Manish, for wonderful presentation. You have extensively. Are you hearing my voice?
Yes, sir.
Yes, sir. Yes.
Dr. Manish, you have given the extensive coverage of the important topics, the drug-resistant tuberculosis. We have to remember, as Dr. P. Agarwal has told, that with the fight from bacteria, tuberculous bacteria, still the mycobacterium is victorious. And every year they are killing more patients what it has killed in the last year. And the second point is important, that the government of India has given assurance to the whole of the country that the tuberculosis will be eliminated by year 2025. These two things. And India is one of the typical country where we are giving economic support to the patient also. Even then, the tuberculosis is mysterious, changing every time. And that's why we are hearing every year something new. This year, Dr. Manish has given that the BPAL-M, we have to remember for drug resistance tuberculosis, BPAL-M. So everything is revolving around BPAL-M. So that's the one point. And my question to Dr. Manish is that why in drug sensitivity test, sometimes the specimen is showing resistance to particular drug, and the second time they are showing sensitive to that drug. Why this is happening in some of my patients? When we are advising for the DST, drug sensitivity test, at one point of time, we are getting the report that these are resistant to this drug. But second time, after 2-3 months, when we are again repeating the tests are coming positive. This is my question to both of the speaker, because the another speaker is going to talk on this brilliant topic. So that's my point. And the second thing, that the drugs BPAL-M, whether it is available outside the medical college hospital or only available in medical college. So that is a 2 point which I want to take from Dr. Manish.
Pranam, sir. You are my mentor, my teacher. You have been my teacher. So it is my privilege to speak in front of you. If any mistake happens, then you can guide. You should guide me, sir.
You have brilliantly described. Brilliantly described.
So first question is regarding discordance in the report. First report is positive. Second report is negative. So answer is, every test of TB, sample of TB should be done in anti-EP accredited lab only.
Okay.
Second is, if suppose first report is CBNAT is showing a rifampicin resistance, then we should immediately subject second sample for LPA. If LPA is showing sensitive, then we should send the third sample for second CBNAT, and out of the 3 results, if 2 samples are showing resistance, then that is resistance. If 2 samples are showing sensitive, then it is sensitive. Regarding second question, BPAL-M, it is available only under programmatic condition, and it is not available over the counter or not available in the private scenario. This is all from my side.
Thank you. Thank you, Dr. Manish. And the last question from you is, what is the difference from RNTCP to NTEM? Is there any change, or it's a change only in
nomenclature have been changed. Previously, RNTCP means Revised National Tuberculosis Control Program. But now elimination has been added. It has been seen that only controlling TB is not enough. We have to eliminate it. So name has been changed from RNTCP to NTEP, National Tuberculosis Elimination Program.
Okay. Besides that, there is no change?
No, besides that, there is no change.
And is there any guidelines for it covering?
Well, I think we should go ahead with the second speaker, because time is limited.
Okay. Thank you, Manish. Thank you.
Thank you, sir.
One question from Manish. Dr. Elias is speaking. One question from Manish. Your talk is very scientific. And in BPAL regimen, one thing is missing, what I think. The one drug which is very wonder to the TB patients, that is the pyrazinamide. The only drugs which acts in the replicating bacteria in inflammatory conditions, when the media is acidic. And in BPAL regimen, there is no drugs which are effective in the acidic media when the bacilli are replicating and that there is inflammation. What's your answer and what's your suggestion?
Sir, it is right that pyrazinamide acts in acidic conditions, but the BPAL-M regimen has come or has been adopted after robust RCTs, and it has been advocated by the WHO and the program has implemented. But your suggestion is very important, and we can do RCTs for including pyrazinamide also in BPAL-M group, and we can see the results.
Dr. Adhilesh, sir, please introduce the second
and just for curative aspects, your talk on the curative aspects, but the most important aspect is the prevention aspects. There are two aspects of any disease. One is prevention and second is curation. If you cure the disease but you do not prevent the disease, you cannot eliminate the TB from all over the world, even in India also. Thank you, sir. Okay, go ahead.
Dr. Adhilesh, sir, please introduce the second speaker.
Okay. Sir, so Dr. Agrawal, please, please you just introduce in my view.
Over to Dr. P. Gopichand. Over to Dr. P. Gopichand.
Sir, good evening, sir. Sir, am I audible, sir?
Yeah,
Yes, you are audible.
Sir, are my slides visible, sir?
Yeah, visible.
Sir, thank you, sir. Good evening, respected faculty and senior faculty. Myself is Dr. Pallam Gopichand, Assistant Professor in Department of Microbiology, AIIMS Patna. I would like to first thanks the organizing team for providing me the opportunity to speak on recent diagnostic methods for tuberculosis. So, as Manish sir told previously, there are plenty of regimens available for treatment of tuberculosis.
Dr. Pallam, it is not coming in the full screen. Can you make it full screen?
Sir, is it okay, sir?
It is not full screen, Manish. No, Dr.
Is it coming in full screen, sir?
फुल स्क्रीन आ रहा है आपके पास, हमारे पास नहीं आ रहा है ये फुल स्क्रीन. Okay, you can go ahead. Still, it is visible. Okay.
I'll just do one, sir. Sir, is it visible, sir?
Yes, it is visible.
Yes, sir. So thank you, sir. So as Manish sir was saying about, there are plenty of regimens available, but I would like to emphasize that before a starting of any regimen or for any disease, there should be a perfect diagnostic test that should be done. Because as we are dealing about multi-drug resistant tuberculosis, which is a major concern and major problem, first, whether the diagnostic tests available for detection of pathologies, because see, what are the different available tests which are available, which are presently in the market. We'll look into it. Before that, the major concern of this particular NTB strategy, which was done in 2015 actually, was to end TB by 2030 or 2035. But whereas National Tuberculosis Elimination Program has set 5 years earlier than the world ahead. By 2025, they have to reach some sustained developmental goals to reduce the incidence by 80% or to reduce the mortality by 90% or any death case rate by 0%. So to achieve that, they have different pillars. One of the major pillar, and which has a major technological breakthrough, is the third pillar, that is the intensified research and innovation. Until unless we have a new tools available for identification as well as for identification of drug resistance of TB, which is directly correlating with the regimen. Until unless we do not identify the tuberculosis and as well as identify the resistance pattern of Mycobacterium tuberculosis, we may not going to and reaching the pattern of using the regimen, and will be satisfying the entire treatment. So the major pillar is the third pillar, that is on research and critical to break the trajectory of epidemic and reach the global targets. It aims to intensify research from the development of new tools. That is one of the today's topic, and also design, implementation, scaling up of innovations, and calls for urgent boost up in research investments. So how does it works is it's works in two different components. One is discovery and development of rapid tools, because we know that Mycobacterium tuberculosis, uh, it takes a very long time for identification. Previously, for example, it was previously identified by LJ medium, which usually takes around 8 weeks, and it was innovated by one more culture methodology, that is liquid culture methodology, that is MIGIT, which has reduced the turnaround time to half, that is within 4 weeks. So this kind of discovery and developments, and not only that, there is one more new technology which has been come is CBNAT, which has revolutionized diagnosis of Mycobacterium tuberculosis within 2 hours or within the same day of the submission of the sample. So these components helps us for reducing the incidence or reducing the uh, impact of mortality of Mycobacterium tuberculosis. So this is a global tuberculosis report of 2020, where they have mentioned to end the WHO strategy to reduce 80% and 90% of TB deaths.
Dr. Pallam, your slides are not moving. Are you still on the first slide?
No, sir, I have moved, sir.
But it is not moving.
I'll start once again, sir.
Yeah. Now it is moved.
Sir, is it moving, sir?
Yes, now it is moving. Yeah.
Yes. So just a brief about these are the three pillars we have. The third pillar, which works about the development of new tools, and this is the Global Tuberculosis Report of 2020, which emphasizes that to reduce the TB incidence. How to reduce the TB incidence is by diagnosing the infection as early as possible before it creates a major damage to the host. So the overview of this particular webinar is what is the progress of development of tuberculosis diagnosis. So we have different technologies endorsed by WHO, which we are currently following it. Technologies under evaluation, which are under WHO, which are available in market but not evaluated by WHO, and technologies which are under development. Sir, are my slides moving, sir?
Yes. No.
Yeah. So these are the current technologies endorsed by WHO. So we can categorize by based upon, if you can see the right side lower, it is microscopy. That is the most commonly used. That is by using light emitting diode, or we can use light microscopy for diagnosis as well as for treatment monitoring. But it has a major drawback, because if you want to get a microscopy positive, we require at least 10 to the power of 4 bacilli. That means at least 10,000 bacilli per ml is required to get a microscopy positive, which is a very lacuna of microscopy, which we were relying for a very long period. So if we don't have enough bacillary load from the patient, we may not get microscopy positive. Then we move on to the next one is culture-based technologies. That
Dr. Pallam, it is on slide number 7. I think you are discussing slide number 8.
Sir?
No. It is not so. Shall I share from my side?
Yes, sir. You, sir. Please.
Let me try. I can I can promise you what will it. Because I joined from the mobile only.
Not an issue, sir.
Let me try. If it is available. Is my slide, is this visible?
Yes, sir.
So you can read it. You are in on slide
Slide
8.
number 8, sir.
Is it visible?
Is it visible, sir? I can do it. So, so these are the different technologies which are endorsed by WHO. Coming to microscopy, that is LED microscopy. Coming to next one is culture-based technology, that we have an liquid culture system which has a detection limit of 1 to 2 bacilli. As previously our seniors have asked me that in CBNAT, first time it was coming negative, second time it's coming positive. That was one previous question asked by one respected senior faculty. The reason could be the minimum detection limit for CBNAT to identify is around 133 bacilli in per ml. If it is less than that particular amount of bacilli, it may not be detecting the particular Mycobacterium tuberculosis. That could be one reason why it is coming negative. That means showing that the quality of the sample was compromised at the first sample, but during the next sample, the quality of the sample has been increased, so that the detection limit for any test, for example, the culture-based technologies has a detection limit of 1 to 10 bacilli. If 1 to 10 bacilli is present in that sample, it can identify, it can come positive. Whereas for molecular detection tests on the left side, if you can see, there are different tests which are endorsed by WHO, especially expert MTB rifampicin resistance. This is the most commonly used CBNAT mission in majority of the hospitals. And even in IMS Patna, I think majority of hospitals will be using this expert MTB rifampicin gene expert machine, which has a detection limit of 133 bacilli. That means at least 133 bacilli is required for detection of Mycobacterium tuberculosis. And also, there was one more question asked by the senior faculty saying that once rifampicin was resistant previously, now it became sensitive. Here, the rifampicin resistance was identified by a probes with 5 different targets of wild types. If there is any mutation of that, will be identified. I mean to say that it is based upon the probes the rifampicin resistance is being getting identified. And secondly, once if it's rifampicin resistant, as Manish sir told, that it has to be sent for LPA. And one of the major disadvantage of LPA, if you can see the second tier, it is only used for acid fast bacillus spear positive cases. Saying that, so LPA can be only used for the samples which are only smear positive. Smear positive in sense, it should be around 10,000 bacilli in that particular sample, then only it can go for LPA. Whereas which is not applicable for gene expert, even 100 to 133 bacilli if it's present, it also detects in a case of gene expert, which is not able to detect in line probes. So these are current uh, um, uh, platforms available. One is Gene Expert in the case of molecular, Line Probe assay, which is for detection of Mycobacterium tuberculosis, as well as it also detects isoniazid and rifampicin resistance. And there is one more which is an Indian platform by MolBio, TrueNat MTB, which is also commonly used in majority of hospitals. It also detects Mycobacterium tuberculosis complex, also detects the rifampicin resistance. So these are the different platforms available for diagnosis. But for detection of TB infection, we usually has one test called as tuberculous skin test, that's Mantoux test, which we was used previously, and it doesn't give a positive result when your immune status is compromised, and especially in HIV individual peoples. people living with HIV. To mitigate that, there is a new platform called as interferon gamma, known as IGRAS, were being used, and it's available in the market. Most commonly used is quantiferon TB Gold Plus, which use an production of interferon gamma, which also helps in immunocompromised status people. So these are some of the tests which are endorsed by WHO. But what are the different new tests which are diagnostic tests which are in the market but may not be evaluated by WHO, but still which may be coming in very near soon? So coming to the left one, that is the molecular test or detection of TB and drug resistance. So the tests which are available in the market and the next generation tests which are available in the market are directly targeting the drug resistance genes, not only the first line drug resistance genes, also they are targeting the second line drug resistance genes, because the entire regimens will be based upon the drug resistance genes, either primary or secondary. Previously, until now we have platforms for only detection of drug resistance of only primary drugs, whereas the newer innovations or newer technologies which are coming up are directly targeting on the second line injectables, on second line drugs which are being used for the regimens like BPAL regimen for detection of moxifloxacin resistance or even pyrazinamide resistance. If you see in this next generation sequence, they want to directly detect the resistance genes from the sample itself. So coming to the right side, corner one, these are some of the new skin tests for TB infection, which is a dye screen test. So previously we used to use a protein purified derivative of Mycobacterium tuberculosis, Mycobacterium bovis usually, which has a lack of sensitivity and specificity for infection, TB infection, which will be huddled by BCG vaccination. And that BCG vaccination, and if you have infection, we want to screen a test, it will be biased. But there are some new skin tests which are available or which are coming into market, which are EDAT, which are early derived antigens of tuberculosis, and whereas a chaperones 10 of the antigen of Mycobacterium tuberculosis, which will be used as an antigen target for detection of infection. So these are some of the new drugs, new methodologies or new kits which are coming up for diagnosis of TB. These are some of the other tests which are under evaluation by WHO. We can see in the left side middle area, they have a different diagnostic test which they directly want to detect a mass scale of Mycobacterium tuberculosis using a Roche Cobas system, which they want to use in a tertiary hospital, which is not available for now. We usually use to do a culture, or we go for a single test of gene expert. They want to do a mass detection especially in tertiary care center. These are some of the platforms available. Coming to the left side, low one, which is Expert XTR TB cartridge, which is a Cepheid based USA company, which they want to detect not only the Mycobacterium tuberculosis, they want to include some other targets which are directly involving the second line drugs, and to prevent or to help to treatment of XDR TB regimen. And one more, which was the left side one, was a Gene Scholar, which is a Japan-based company, where it has a hybridization technique for detection of pyrazinamide. As Manish sir was saying, pyrazinamide detection will help you in resistance detection. But whereas LPA is only available for positive, that is smear positive cases, whereas in smear negative cases, we can use this platform, that is Gene Scholar, which is a hybridization technique for detection alone for pyrazinamide resistance. So some of the other new innovation techniques which are available is or coming up is computer aided detection of digital chest X-ray. So majority of the chest X-rays or majority of pulmonologists might be knowing it, but they have some bias or it's a subject to errors between two different clinicians. especially for in the case of chest X-ray. But there are some new tools which are coming with an AI generated with a machine learning, so they can help out with an computer aided detection of a digital chest X-ray. There are some platforms which are being developed by different companies, which may be coming into the market very soon. There are some other new innovations which are coming is culture-based drug susceptible testing. So at present, we have only a phenotypic DST, that is drug susceptibility testing. We use only midget platform, but we only test for only some selected antibiotics or selected antibiotics in the first line. If they are resistant to first line, pattern like suppose majority have been using Vitek cards where they use a different combinations around some 15 to 20 combination of antibiotics where we can get the information like either sensitive or resistant. They are coming up with that kind of a technology or innovation where they want to give the information about the resistant to a lot of number of drugs. The right side lower one, this is the CTB skin test, which is developed by India, which they are using as well as EDAT, that is the early detection antigen of tuberculosis, and chaperone 10 as an protein purified derivative for as a skin tuberculosis test, which will increase this specificity of mycobacterium tuberculosis infection as a screening procedure and decrease the bias by BCG vaccination. So these are some of the platforms available, or some of the new technologies that are going to come, and they are mainly going to target on the multi-drug resistant TB, which will help the clinicians to start on the regimen on a very timely basis. At the same time, will be decreasing the mortality and morbidity of tuberculosis infection. That is one of the major goals of NTB project by WHO or even by National Tuberculosis Elimination Program of India. So to decrease the incidence as well as to decrease the mortality of TB around 80 to 90%, diagnosis of not only tuberculosis, even the diagnosis of resistance of tuberculosis should be at par with a decreased turnaround of time, so that the morbidity and mortality will be decreased and we can achieve our goals or to eliminate the tuberculosis by the stipulated time. So this is how I can conclude about the recent diagnostic tests that are available and which can help to eliminate or to end the tuberculosis by the stipulated time what we have kept by 2025, or our sustained developmental goals by 2025, which are we are far ahead of WHO, which they have already kept by 2030. So any questions, please?
Wonderful presentation, Dr. Gopi Chand, but because of the paucity of time, we cannot go in detail of the discussion.
Sir.
And no program supposed to be successful without the blessing of seniors and your guardians. I just want to have blessings of our guardians. So first of all, I would like to call Dr. D.P. Singh sir to give us some blessings. Dr. D.P. Singh sir.
Thank you, Chairman Dr. P.K. Agrawal. This is the wonderful occasion, and this is a very important day that we are celebrating. Our API Bihar chapter is celebrating and organized a very good program, although it is going on across the country. And it's a wonderful program, and in which, apart from it has been inaugurated by our National President, Dr. Jyotirmay Paul, blessed by our patron and mentor, Dr. B.V. Thakur and Dr. Kamlesh Tiwari sir, and all my governing body friends and all the HODs, our friend from Bhagalpur Medical College, Dr. Ablesh Kumar has also joined, Dr. Ajay Sinha also joined. But the two topics that was given by the Dr. Manish Shankar regarding this multi-drug resistance or MDR drug management, BPAL regimen and other things. And that was fantastic. And he has elaborately talked about this multi-drug resistant tuberculosis and how the update of it. But you know that the how to prevent it, whether it is latent tuberculosis, drug sensitive latent tuberculosis, that is very, very important because 40 crores of Indians are harboring this tubercle bacilli. And just today itself, Dr. Ablesh Kumar, HOD Medicine as well as HOD Tuberculosis of Bhagalpur Medical College inaugurated, and along with our this superintendent, Dr. Hem Shankar Sharma, what Dr. Gopi Chand was talking about the recent test, that is the CTB test. CTB test containing that this ESAT6 plus TFP proteins 10 and equal proportions. That was given one of the Dr. Bhagishri. And that is the test that although not available for all people, but the healthcare professionals who are exposed to tuberculosis, especially we doctors or we paramedicals, they can be tested. And that is just the combination of benefits of IGRA as well as Manto. And where it is just like Manto, it is 48 hours reading will be there of the in duration reading will be there. And just this will obviate that the BCG overshadow. There will be no effect of the BCG on this CYTB test. Earlier it was called CTB test, but now it is because it has been also been produced in the Serum Institute of India, and they have named this CYTB test, and that is the that is the test, that is a recent introduction in India, and that we can take utilization of that latent tuberculosis, and that must be prevented, and we shall find ways because we have got also rifampicin regimen also, 12 dose regimen. So we physicians, we have got overall 1,000 physicians in Bihar, more than 23,000 in India. We all physicians must come together. All paramedicals should come together. And as you know, that in COVID, all India was all united to fight against this COVID. And Dr. Ajay Sinha is one of the hero of that. And similarly, in tuberculosis, our Prime Minister has said by 2025, whether we are going to end tuberculosis by 2025, just 9 months has left. But we, India, can do miracle. Everyone, this 140 crores people unite and fight this NTB program. And to achieve this goal, India must focus on multi-sectorial intervention. Funding has decreased from internationally. There is problem in that. The improved access to the healthcare, rural and urban facilities. The innovative ideas like this digital these methods and other methods, mobile techniques, we can reach to the people where we have not gone, high-risk patient. We have to increase the diagnosis. We have to decrease the mortality. Still, India contributes 29% of the mortality of the world. Why today? Why the tuberculosis, which is a preventable disease, treatable disease, why any patient of tuberculosis should die? Even the mention of Dr. Ablesh Kumar that why not pyrazinamide is included in that. It's a wonderful drug. You have not taken the cultural sensitivity of the BPAL regimens about this. Pyrazinamide should be, that's to trial should be there because bidarpulin resistance has often today reported. And when it will go our way, we don't know. So with the message that yes, we can end tuberculosis, for that you must be committed. For that you must invest not only time, money, but all sort of things we can invest. Only then we can deliver the good to end tuberculosis program. And before I close, I must pay my sincere regards and pranam to our mentor, guardian, Bhishma Pitama of API, Dr. B.V. Thakur, sir. Pranam, sir.
Wonderful input, sir. Without this input, this session supposed to be incomplete. I would like to call Dr. Devi Ram, sir. Dr. Devi Ram has joined. Dr. Devi Ram, sir. Dr. Hem Shankar, sir. Dr. Hem Shankar, sir. Dr. P.K. Sinha, sir.
Dr. Amit has joined. Dr. Bibi Thakur, sir, is there.
And Dr. B.K. Singh, sir.
Dr. Amit is here.
Dr. Amit.
Yeah, Dr. B.K. Singh is also here. Yeah.
Dr. P.K. Singh, sir. Please bless this occasion with,
I
with your
really
progress.
congratulate Dr. P.K. Agarwal for a wonderful start in this first program after swearing in as a chairperson of our API Bihar chapter. Because I late joined, because I am busy with the RSSDI conference program, and fortunately the press conference was going on that during the program. But what I have listened, that program is very, very wonderful, and it is nearly 100 people joined this program, and that shows the success of the program. So my pranam to the all seniors and colleagues, and thank you very much for inviting me, Dr. P.K. Agarwal. Thanks a lot.
Thank you, sir. I now request our past chairman, Dr. A.K. Das, to give his input. Dr. A.K. Das, sir.
Thank you, Mr. President. Respected Bibi Thakur, sir, Dr. D.P. Singh, sir, Dr. Ajay Sinha, and all stalwarts of API Bihar. The meeting of API Bihar has more than 100 attendance. It shows how strong we are, how connected we are, how cohesive we are. Thanks everyone for joining this meeting. At the outset, I must congratulate Dr. P.K. Agarwal sir and Dr. Devendra Bhushan for organizing this World TB Day on the Zoom platform. On this World TB Day, though the motto is, yes, we can end TB, and then goes the CID. Commit, invest, and deliver. I must say that we, as a country, preponed the End TB program to 2025, but the challenges are huge. WHO says we can target End TB program by 2030, but we have preponed to 2025. So the country, the head of the country, our respected Prime Minister, has already given a daunting task to all physicians and to all countrymen to fight this disease not only on one platform, but on multiple platforms, on social platform, on delivery of medical services platform, on research and development platform. So we all need to gel together and include all parts of medical science to fight a very, very difficult to treat many times a disease which mimics so many other diseases at many times. So the challenge is ahead of all of us, and we need to fight together. The topics which we'll discuss today were marvelous. We all need to understand the new BPAL-M regimen. We all need to understand what's in store for the diagnosis of difficult to treat and resistant tuberculosis. We need to dream of a situation where we can diagnose resistance at the very outset from a single drop of blood. Life will be easy for all of us to then to treat, select the drug, and then to treat. So challenges are ahead, but we all are examples of success against the challenges. So let's gel together, let's commit together, and let's deliver together. Thank you very much.
Thank you, Dr. Das. अब सबका सार पाने के लिए we should move towards the Gangotri, and our Gangotri is Dr. B.V. Thakur, sir. Sir, please.
Dear friends, am I audible?
Yes, sir.
I must congratulate the executive body of API Bihar chapter under the leadership of Dr. P.K. Agarwal, Divendu, and many more. And I'm sorry for the last 9 weeks, due to reasons best known to my friends, I have not been on this Zoom meetings and screens. In spite of my best efforts, I could not join early. But thank God, the moment Manish started his talk, I joined. And I tell you honestly, I'm wizened. I graduated in 64. Therefore, it's very difficult for me to assimilate whatever the friends have said. Friends, it's very novice, very easy to say that we can control tuberculosis by 2025. But I'm afraid we will not be. I'm sorry to say so. In spite of the fact that the Manish and Gopichand, by Gopichand, it has come in my mind that there was a Gopichand Jasus. So he has done Jasusi on all fronts regarding the diagnosis of tuberculosis. It was wonderful. Both the talks were wonderful. But mitigating any disease, controlling any disease to the last extent, we need to have time. Do we have time? Do we spend time for the social cause? Do we go to the periphery? I'm very happy that Agarwal had arranged a meeting of public awareness, and the attendance was too good. So until are we spending time with a tuberculosis patient, and are we telling them how they can prevent the infection to their other family members? Are we honestly doing it? I'm sorry, we are not. I do it, that is a different thing. But how many patients do I see nowadays? I see only those patients who are forcing me to see, honestly. So friends, first, अपने गिराबान में देखो. Go to the public. You see, there is a theme of this diabetic meeting, from bench to bedside. So we are very talkative on the bench. But when it comes to translating it into the public welfare, Medicare, there we fail. And rightly told by Dr. The prevention is equally important. We are trying to identify, we are trying to treat only those patients who are suffering today. And they are spreading the disease to other people. There are a lot of methodologies to prevent it. Although it is too late, but I tell you one thing, what I do. I tell to the patients that, that you have, हमारे यहाँ पतकी होता है ना वो मिट्टी का, get few 7 at least or 15 earthen pot with a cover. Ask your patient to use mask, isolate him in the house, ask him to cough in that earthen pot, and then dig the ground and then put it in the deep ground. This we are not doing here. We don't have time. But at the end of the day, I congratulate my dear friends who have talked a lot about me, which I don't hardly deserve, but still then. So the day has been very, very successful, and rightly told by Amit the success of any meeting is the number of participants. I had given some hint to my friend Dr. Agarwal how to increase the number of attendees, and he has done it well, very good. So friends, I congratulate, I bless Agarwal, then the Secretary Sahab, Manish, and Gopi Chand Jasus. And I thank and congratulate all the participants who must have as wizened as I have been. I may not be able to retain it, but the young mind can retain it also and translate it into day-to-day practice. Thanks, Agarwal, for asking me to speak from few lines. I bless everybody because possibly I am the eldest amongst all. God bless all of us. Good night.
थैंक्स सर, आपकी डांट और सजेशंस हम लोगों को हो सकता है कि वी गो मोर क्लोजर टू सोसाइटी. थैंक यू सर. Now I request Dr. Divendu to give the vote of thanks.
Thank you, sir. So it was indeed a pleasure to have all the senior faculties of the Bihar at this platform. Although we started late, in the sense that we have taken over the charge in November. But yes, we will continue with the good things in the future. So first of all, I am thankful to our speakers, Dr. Manish Shankar sir from IGMS and Dr. Pallam Gopichand sir from AIMS Patna, who has beautifully described their topics. I am thankful to our patrons, Dr. B.B. Thakur sir, Dr. Kamlesh Tiwari sir, Dr. A.N. Rai sir, and Dr. D.P. Singh sir, Dr. C.B. Prasad sir, Dr. Ashan Misra sir, senior governing body members, Dr. A.K. Das sir, Dr. D.P. Singh sir, Dr. Himshankar Sharma sir, and the all senior members who have joined, Dr. Hema Kumari madam, Dr. Mangilal sir, Dr. Nishikant, Dr. B.K. Singh sir, Dr. Binay sir, Dr. Devkant sir. So many of, I may miss a few names, so excuse me for that. So I'm thankful to all, and I promise that we will continue with the same goodwill. Thank you.
Thank you, sir. Thank you. Good night, sir.
Thanks a lot. Hats off to the new team. Well done. Good job. Congratulations, Dr. Agarwal, Dr. Divendu.
Thank you. Thank
Many more to come.
you. Sure.
Thank you. Bye-bye.
Thank
Good night. Good night, sir. Pranam, sir.
Thank you, sir.
God bless.
Thank you, sir.
Good night, everybody.
Good night, sir.
Good night.
Good night, everybody, sir.
Good night, sir.
Good night, P.K. Agarwal.
Good night, sir. Good night, sir.
Excellent.